Hello everyone, good evening. Welcome to the second webinar in the IAB certification course for basic bronchoscopy. This is our third certification course after thoracoscopy and EBUS. This time we'll be having 12 online modules and 5 physical workshops on popular demand. For anybody to gain the certificate, they have to attend at least 10 out of the 12 webinars for at least 90% of the times. We are watching you. How much are you attending? And you have to attend at least one physical hands-on workshop. Believe me, when you hear the faculty, you will realize that you have to attend 12 out of 12 because the knowledge from them is pure gold. For today's webinar, we have a star-studded faculty, and we have the captain of the ship, Dr. Ujjwal Parak, sir. Can you put up the slide, please? Dr. Ujjwal Parak needs no introduction. He's a senior consultant, vice chairman of the respiratory medicine and interventional pulmonology at Shri Gangaram Hospital, New Delhi. Sir has more than 27 years of clinical experience in the field of pulmonology. He is the joint secretary for Thoracic Endoscopic Society, and his areas of interest are interventional pulmonology, interstitial lung diseases. Sir, I hand over this stage to you. Please, sir, take care.
Good evening, everyone. Thank you, IAB, for inviting me to moderate this session. And today we are going to be talking about something very, very basic of bronchoscopy. And this, I hope, is going to be very useful for all the young people who are joining this webinar. In this webinar, we have a star speaker from Kolkata, Dr. Shyam Krishnan. He's been talking about basically about how to utilize CT scan to understand the concept of doing right bronchoscopy. So without wasting our time, I'll first be introducing our speaker, who is Dr. Shyam Agarwal. He's from Chennai. He's from the Birla Institute, and he has been very, very active academician. He has been part of DNB teaching program also. So I invite Dr. Shyam Krishnan to kindly deliver his talk.
Thank you, Dr. Parak. So for the very warm introduction. Good evening, everyone. So the talk I'm going to give is basically, it's probably the most important part of if at all you want to get into interventional pulmonology. This is the preparatory step you need to take before you actually step into your bronchoscopic suite. I mean, whatever it is, you have to be very well versed with your CT. You need to know where the pathology is, which part of the lung the pathology is, and so that you can take a targeted sample from that particular place, be it a lavage, be it a transbronchial biopsy, be it a needle aspiration, whatever it is, you need to know your anatomy very well. So how surgeons need to know their anatomy well before they operate on a patient. Same for us. We need to know the anatomy. We need to know where we are getting into and how to approach. So if it's a lung nodule, the future is all about diagnostic bronchoscopies. We've seen all the, the innovations and the advancements in interventional pulmonology focused on peripheral nodules. And I feel that would be the future also. Central airway diseases are, getting far and fewer because of early detection and better precision medicine in oncology. We would have a lot of nodules to deal with in the future. And for that, you need to know the path you need to go to, arrive at that nodule. So, this would set the stage. I feel all of you over here, the audience, whoever is participating or listening to this talk, you should get your basics right. So CT anatomy is probably the most important step before you decide, to go in with the bronchoscope to the patient. So I'll share my slides. Yeah, I hope it's visible. Yeah. So this slide said this. So this is prepared by Dr. Modi and his team. I'll be presenting them. So if you see the the bronchial tree, it's basically you would see the right and left. You would see the trachea first, which is further divided into the right and left main bronchus, and it further divides like a branch of a tree into bronchioles. And you have bronchioles up to the 5th to 6th generation, and then beyond the 16th generation, you have the terminal bronchioles, where there's no cartilage; it's just tissue, and you have the terminal bronchioles basically divide into respiratory bronchioles, which then further divides into the alveolar ducts, and eventually they end up into the alveolar sacs, where the the oxygen and the gases are they enter the bloodstream. So our playground is basically the main bronchi and probably up to the 4th or 5th generation bronchioles. So what are the characteristic features of a bronchopulmonary segment? The bronchopulmonary segment is basically the largest subdivision of the lung lobe. It's pyramidal in shape with the apex towards the root of the hilum, and each segment is an independent respiratory unit. And you know that each segment has its own artery, which are the branches of the pulmonary artery. It has a segmental bronchus. It has the autonomic nerves and the lymph vessels. So you would notice that I haven't mentioned the pulmonary vein because the segment does not have a pulmonary vein. The pulmonary vein are interspersed in the interlobular septa. So the segmental vein runs in the connective tissue between the adjacent bronchopulmonary segment. Thus, a BPS is not a bronchovascular segment as it does not has its own vein. And you would also know that the infection basically in a bronchopulmonary segment tries to be restricted to that, but conditions like TB or bronchogenic CA, where you have an hematogenous spread, it might spread from one segment to the other. So this is a picture of the bronchopulmonary segment, where you can see the illustration showing a terminal bronchiole in green color and a pulmonary artery accompanying it marked in red. And you can see that the terminal bronchioles ending up in air sacs, that is the alveoli. And you can see the pulmonary vein at the periphery of the interlobular septa, where they're shared by the adjacent bronchopulmonary segments. So if you see the segmental division, so the trachea divides into the right and left main bronchus, and the right main bronchus further divides into the upper lobe bronchus and the right bronchus intermedius. And as you go down, the bronchus intermedius divides into the right middle lobe and the right lower lobe, which further divides into the bronchopulmonary segments. In the right upper lobe, you have the right anterior, posterior, and the apical segment. In the middle lobe, you have the medial and the lateral medial segments in the middle lobe. And then as you go down, you have the superior basal segment, and then you have the anterior basal, medial basal, lateral basal, and the posterior basal segments. On the left side, you have a left upper division bronchus and the left lower upper division bronchus, which further divides into the left upper lobe bronchus and the lingula. And then you have a left lower lobe bronchus. So the left upper lobe bronchus, the apical and the posterior are unified together here. So you call it the apico-posterior segment. Then you have the anterior segment bronchus, and then you have the lingula. So the lingula is further divided. You don't have a middle lobe over here. So the left side, it's always the lingula. So the lingula is divided into the superior lingular segment and the inferior lingular segment. And the left lower lobe, you have the superior basal, anterior medial basal, and the lateral basal. So you don't have a medial basal segment over here. Or you can also, so the new nomenclature is you have the superior basal, anterior, lateral, and the posterior basal. So that you don't have a middle basal, medial basal segment over here in the left side as compared to the right. So if you want to locate the bronchopulmonary segments on a CT scan, the most commonly used levels are at the level of the aortic arch. And then the second common, so in the left side, you have the level of the left pulmonary artery. You have in the right side, the right pulmonary artery level, and at the level of the cardiac ventricles. But when I illustrate I would go through the, how to interpret the bronchopulmonary segments probably in the coming few slides. So if you see over here, at the level of the aortic arch level, it's basically purely the upper lobe bronchopulmonary segments. So in the right and the left, so you have the upper lobe segments. So in the right side, you have the apical, anterior, and the posterior segments. And in the left side, you have the apico-posterior and the anterior segments. So at the level of the left pulmonary artery, you have the, in the right side, you have the anterior segment. Then you have the apical posterior, and then you have the major fissures dividing the lower lobes. In the left side, you have the superior and the inferior lingular segments. You have the the major fissure dividing the lower lobes at the level of the left pulmonary artery here. So, and again, you can see over here where they divide, the fissures divide, and you can see the different segments of the, the right and left main bronchus over here. And at the level of the ventricles, you can see the basal lower lobe, the basal segment. So you have the major fissure. You can see the middle lobe, the medial and the lateral lobes of the middle lobe in the right side. And in the right lower lobe, you can see the anterior, the lateral, and the posterior basal segments. Similar for the left side, you can see the basal segments, the anterior, lateral, and the posterior segments. And so above the fissure, you can see the inferior segment of the lingula. So I will probably run through this. This is probably easier to interpret. So I'll go through the CT scan over here. So this is basically a CT scan of the lung. So if you see, as we go down, you can see the trachea. It's dividing into the right and left main bronchus. And you can see the major fissures over here marked as MF. So the major fissures start to appear at the level of somewhere on the carina, which divides in both in the right and left into the right upper and middle lobe from the lower lobes. So let's concentrate on the right side first. So if you see over here, at the level of the carina, you see the major fissure. Then the carina, it's dividing in the right main bronchus and the left main bronchus. And then as you go down, you will see that a small notch appears. Yeah. So, yeah, you can see a small, you can see this particular bronchus, that is the RB1 or the apical segment of the right upper lobe. So this is, and as we go slightly down, you can see the RB2, so this is the RB2 over here. That is the posterior, that's the dorsal part of the right upper lobe. That is the posterior segment. And then you see the RB3 or the anterior part of the right upper lobe. So the anterior segment of the upper lobe. So apical, posterior RB2 and RB3 is the anterior. And as we scroll down, we're scrolling down and you can see the middle lobe, the ostium of the middle lobe over here, the marked in the green star. And you can see the lower lobe bronchus over here. And you can see the superior segment of the right lower lobe, superior basal segment, which is the RB6. And then as we scroll down further, you see the lateral segment of the right middle lobe, that is the RB4. And then you see the medial basal segment, medial segment of the right middle lobe. So the medial segment is RB5. Then we are now entering, so RB4 and RB5. So RB4 is lateral segment and of the middle lobe, and RB5 is the middle. We're scrolling down, and then we can see we enter the right lower lobe, and the right lower lobe, RB7 is the medial basal segment of the right lower lobe. And we're going further down, and we see the three segments ALP, that is RB8 is the anterior basal, RB9 is the lateral basal, and RB10 is the posterior basal segment of the right lower lobes. So you have the 10 bronchopulmonary segments over with you. The nomenclature is very important because when you proceed further learning the bronchial branch tracing, chasing the pulmonary nodules, you would see an advanced version of this particular nomenclature. Let's start with the left side now. I'll start over again. So now we're going into the left side. So you can see the left. So this is the LB1 and LB2. That is the left upper lobe division. And then you can see that is the apico-posterior part. And then once you scroll down, you see the LB3. That is the anterior segment of the left upper lobe. So apico-posterior and anterior segment. We're scrolling down further. Here we see the lingular segment. So this is the lingular segment over here. And the lingula divides into the superior and the inferior. So superior lingula is LB4, inferior lingula is LB5. So you see this. So the one marked with the green star is LB4, that is superior lingular segment. And then LB5 is the inferior lingular segment. And we further scroll down. And here you can see, you see the left lower lobe, you see the LB6 or the superior division of the left lower lobe. So this is very similar to the right side where you see the superior division. So here it's LB6, the superior division of the left lower lobe. And then you scroll down further. And once you scroll down further, you will see that it further divides into the three parts, the anterior, lateral, and the posterior. But see, we don't have a medial. So we don't have an LB7, So in the right side, you could see this part. So this is RB7. So here you don't see any accompanying, a medial basal segment. So there is no LB7. So it's just you have the you don't have a medial basal. So you have the anterior, that is the LB8 anterior basal segment. Then you have an LB9, which is the lateral basal segment. And then you have the LB10, which is the posterior basal segment. So you have only 9 bronchopulmonary segments in the left side, and you have 10 on the right side. So this is in short, the basics which I feel all of you should know regarding interpretation of the bronchopulmonary segments. So now it's just a couple of concluding slides. So, bronchopulmonary segments is a misnomer as it does not have its own vein. You have 10 segments on the right side and 8 or, 9 on the left. So basically the apical and posterior is combined. So you have 8 on the left side. So there are a lot of common variants in the anatomy of BPA, of the bronchopulmonary segments. So you can try, dividing the CT at different levels as we had mentioned before, or you can just use the major fissure as the landmark and methodically scroll down and see each particular segment. So you see at the aortic arch level, you will see only one upper lobe BPS and you name them from the anterior to the posterior aspect. At the level of the left pulmonary artery, the lingular divisions come into display. However, the right middle lobe divisions are seen slightly lower at a lower level, and they might be at the level of the right pulmonary artery. And below the major fissure, at the level of the left or right pulmonary artery, lies the superior segment of the lower lobe, and it never touches the diaphragm. At the level of the ventricles, just below the fissure, you have the basal segments on the right, and you have the medial, anterior, lateral, and posterior on the right side. And on the left side, you don't have the medial basal, you just have the anterior, lateral, and posterior on the left side. Try to correspond all the images on the sagittal, coronal, and lateral views. And you start seeing the CT scans on the CT console, discuss with your radiologist. Try to ask the patient for the CD, because you can load them onto your packs and you can load them onto your computer and see this, because it's very tough to look at just films, because the films are basically, the images are handpicked by the radiologist, whoever prints out the films. So thank you. I'm sure there'll be a lot of questions which the panel would be answering.
Thank you, Dr. Sham. Well, you are also part of the panel, so you'll also be answering. Thank you very much for a very wonderful talk on how to interpret a CT scan and how to actually understand where the lesions would be when we will be planning to do a bronchoscopy. Now, coming to the second part of our today's webinar, which is a panel discussion. Here we are going to increase the scope of our discussion to right from the indications, contraindications, then how to sterilize the instrument as well as prevent the infections through the infections through the bronchoscopy happening to people. So this is how we are going to broaden our talk today, discussion today. And to discuss this, we have a very extensively, I would say, experienced and in faculty which is from all the places of the country. And to lead us is Dr. Nitin Abhyankar. He doesn't require any introduction. He's from Pune, and he has been a very active person in our field and has been training a lot of people over the years. I welcome Dr. Nitin Abhyankar. Uh, then I welcome Dr. Jayaraman. He's from Chennai, and he's a senior consultant pulmonologist from the Bill Roth and Apollo First Medical Hospital. And he is a keen interventionist, and he has been involved in a lot of doing a lot of procedures, interventional pulmonology, as well as sleep disorders. So I welcome you, sir, to this webinar.
Thank you.
The third panelist of today is Dr. Amina Mobashir. She's from Delhi, from Max Group of Hospitals. She's a senior consultant, and she's going to be the part of our webinar today. And the last but not the least is Dr. Ganapriya. She is from Trivandrum, and she's a very active interventional pulmonologist. She has been part of these webinars in the past also. So I believe that we have a full flare of our faculty from all over the India, and we are going to be dealing with the most difficult part, which is answering the questions of very basics, like how to when to do a bronchoscopy. This is the beginning of doing any procedure, that we should have the right indications, and the right person to answer this would be Dr. Abhyankar. Dr. Abhyankar, can you tell us what would be the right indications to do a bronchoscopy or a bronchoscopic procedure?
Yeah, I think it's one of the toughest questions. And if you're trying to say from basic bronchology to the most advanced bronchology, it gets tougher and tougher and tougher. But at the same time, let me stick to the basic bronchoscopy because that's our agenda today. I would say undiagnosed infection somewhere in the lung, either in the form of a consolidation, green bird, whatever that appearance is, which is not making sense to me, and it is possibly causative for the patient's symptomatology, whether it is fever, weight loss, or whatever it is. So I think that's going to be one of the most important indications. So, for example, somebody has even a right lower lobe tree and bird appearance, and I don't know what the reason for that is. I am possibly going to put in a scope and take a sample from that area. So I think that's the first of the diagnostic, needs. The other one obviously is a collapse, a complete collapse of a lobar or even for that matter, entire lung. But entire lung is very unusual. I mean, that's an obvious indication maybe in the ICU segment, but say a lobar consolidation, lobar collapse. I think that's going to be another indication, because why would be a lobar collapse? That's the second part of the component. And therapeutically, I am not sure whether we are really with the agenda, but therapeutically, I would do it for two reasons. One, in the ICU settings, for removing secretions which are retained and patient is not able to cough it out. And the second one is, of course, going to be stopping the bleeding. I think I'll stop here because I think otherwise the 12 modules that we have will not make much sense. So I think
Right.
let it go. Yes.
Thank you, Dr. Abhyankar. I think you have dealt it very rightly. So basically, there are two parts of our doing bronchoscopy. One is diagnostic, and the other part is therapeutic. So in diagnostics, any opacity which we on an X-ray or a CT scan, for which we have not been able to make a diagnosis by non-invasive methods, we would definitely try and make a diagnosis with the help of bronchoscopy to cut it short, the diagnostic. And the therapeutic part, if we have made a diagnosis and we can make some changes in the airway to help the patient, then probably a therapeutic bronchoscopy would help. And I think one of the important reasons to do a bronchoscopy would obviously be a therapeutic one, would be a foreign body. So that's something which can be done with a basic bronchoscopy. So we are going to be sticking to very, very basic things. We will not be delving into a very difficult areas which are going to be confusing for the patients or to the attendees. So now coming to the part, we know when to do a bronchoscopy. We have discussed this with Dr. Abhyankar. But when do we say that we do not do a bronchoscopy or the patient is not fit to do a bronchoscopy? And to answer this question, I would invite Dr. Jayaraman to kindly answer this question: when not to do and what are the contraindications for doing a bronchoscopy?
Thank you, Dr. Ujjwal Parak sir, and thank you, IAB, Dr. Amita ma'am, and Megul sir, and all the team, RP Meena sir, for this wonderful opportunity to take part in this prestigious IAB certificate course in bronchoscopy. So today we are discussing about the bronchoscopy. So Nitin sir told very clearly about the indications of bronchoscopy, when to do bronchoscopy. So my question to the answer is when not to do bronchoscopy or contraindications of bronchoscopy. So bronchoscopy contraindications are, there are three categories. One is the absolute contraindication, other one is the relative contraindication, and third one is we have to consider certain conditions we have to do the bronchoscopy or not. First is absolute contraindication. Which are the conditions we don't do bronchoscopy at all? Very, very important. Absolute contraindication. Severe hypoxemia. What is severe hypoxemia? Due to various etiologies, primary, secondary, primary to lung or secondary to multi-organ, whatever the etiology behind. Severe hypoxia. If you see the SpO2, pulse oximeter reading is less than 90, despite the supplemental oxygen, patient is not maintaining the oxygen saturation. And if you do the ABG, you are seeing the PaO2 less than 60 millimeter of mercury. This is called, we call it as a severe hypoxemia, is the absolute contraindication. And hemodynamic instability, unstable hemodynamically. Example, patient is on cardamom for atrial fibrillation and 2 inotrope or 3 inotrope supports for the BP maintenance. And other multi-organ dysfunction patients, this hemodynamic instability is the absolute contraindication. And uncooperative patient or unwillingness patient is telling, I don't want any bronchoscopy, leave it alone. So in case of conscious normal individual, they're telling, I don't want bronchoscopy, so don't force to do bronchoscopy. And severe bleeding diathesis or bleeding disorder patient, these four conditions are absolute contraindication. What are relative contraindication? Recent myocardial infarction, recent stroke. So we have to wait for 3 to 6 weeks time, then plan to do bronchoscopy. Severe bronchospasm due to various etiologies, acute severe asthma, or in the case of other abnormalities, COPD, severe bronchospasm, we have to optimize the patient, then only we can take him up for the procedure. And acute respiratory failure due to various etiologies, severe pneumonia or severe pulmonary, whatever the etiology, we are going to bronchoscopy. It's a relative contraindication. And severe pulmonary arterial hypertension due to various etiologies or relative contraindication to bronchoscopy. Considerations mainly in patients on anticoagulation, clopidogrel, heparin, and other medications. So when to do bronchoscopy? We have to wait for 3 to 5 days minimum stoppage of medications. We have to do bronchoscopy. Anesthetic risk, we have to carefully choose the patients. Any anesthetic drug, reactions we have to see. And the inexperienced operator. So young people, young bronchoscopists. So we have to do the very important, they were going to do the bronchoscopy, bleeding and other things. And the lack of emergency support or backup support. Backup support is very important. Any severe hypoxemia may require NAB or intubation. So we have a team. So these are all the contraindications not to do bronchoscopy. We have to stabilize, optimize, then choose meticulously. This is the youngsters, those who are finishing recent graduations to do bronchoscopy, IP. We have to carefully choose the patients. So doing bronchoscopy and not to do bronchoscopy are very important. Thank you, sir.
Thank you, Dr. German. You have very nicely divided the contraindications into three groups. To me, I would say that with the availability of the expertise and the anesthesia backups and all the medications, modern medications, the absolute indication would be probably two. One, when we have made a diagnosis, or we can make a diagnosis without being invasive. So that's the first contraindication. So this is very, very clear that bronchoscopy needs to be done in patients who have not been diagnosed without any invasive procedure, right? So number two would be a patient who doesn't want a bronchoscopy. So these probably are the two absolute contraindications. Rest everything is relative, because they might be diagnostic reasons to do a bronchoscopy, or they might be a therapeutic reasons to do a bronchoscopy. Obviously, you will take more challenge, more risk in doing a therapeutic procedure rather than a diagnostic procedure. Right, right. Now now we know what the indications are, what contraindications are, but we need to have little more information before we go into do a bronchoscopy. And the most important information that comes to us is through imaging. So I would like to ask Dr. Amina, what role does imaging plays in preparing before doing a bronchoscopy?
So, thank you for the question, sir. First of all, I think you very nicely said that an imaging modality would first of all tell us whether a bronchoscopy is needed or not, whether there are other ways of accessing the lung for a diagnosis. Imaging modalities, particularly the CT scan, provides us a 3D view of the airway. So, this gives us a roadmap to the target lesion, particularly for the small peripheral areas that are difficult to access, where maybe, we can take a decision of what size of the bronchoscope maybe use if we want to use a thinner scope. Then it helps us improve the diagnostic yield, because here we know exactly which segment to target while taking the BAL and the biopsy. So the diagnostic yield, of course, goes up. If there is a CT bronchus sign, again, it is proven that the diagnostic yield goes up. And in as early as the 2000, an RCT was done where bronchoscopy with and without CT was compared, and it was noted that an 18% higher diagnosis was achieved when you do a CT scan before. Now, the other thing for which a CT scan becomes important is also for the characterization of the airway obstruction if we are dealing with one. So the location, the extent, the type of obstruction, distinguishing between an intrinsic and endobronchial obstruction versus an extrinsic compression. So we can plan the procedures like stenting with a fairly decent idea of what size of stent do we need. For debulking also, we can get a fair idea of the base and extent of the endobronchial growth, etc., which instruments to keep handy. Then, of course, again, for the advanced techniques, like if there's a lymph node, we can go ahead with the TBNA, navigational bronchoscopy, etc.
Right, right. So basically, imaging is important. Imaging, any form of imaging. Obviously, the first is going to be an X-ray. Rightly said that a CT scan is now becoming very, very common radiological investigation before doing a bronchoscopy. But X-ray also can give a lot of information, and that can itself be enough to think about doing a bronchoscopy. And then comes the CT scan. Now, bronchoscopy, I'm just taking a little more time. Bronchoscopy basically divides the lesions into two: central lesions or a peripheral lesions. Whatever we can visualize through the bronchoscopy is a central airway lesion, and whatever we cannot visualize through a bronchoscopy is a peripheral lung lesion. So CT scan would help us in dividing these two things and then deciding which all modalities of investigations we might be requiring when we are doing a bronchoscopy. So CT scan at least an X-ray is very, very important before we actually think of doing a bronchoscopy, unless we are in an emergency and we think that patient has massive hemoptysis, or the patient has got probably a strong history of foreign body, where we may go in to do a bronchoscopy without an imaging. Most of the time we are going to be doing it with this, but no two modalities, CT scan or bronchoscopy are same. They give total information. So to answer this kind of a question, I would invite Dr. Ganapriya that what is the sensitivity and specificity of a CT scan in identifying the endobronchial lesions as compared to a bronchoscopy?
Thank you, sir. So when it comes to endobronchial mass lesions, CT scans will give you a good detection rate, high detection rate, close to 90 to 95% if read by well radiologist and us. But but for other airway lesions, like when it is a mucosal erosion or ulcers that you see in your vaginas, or certain smaller nodules that you see in sarcoidosis, conditions like sarcoidosis, and even dysplasia and inflammation. These are things which are most often missed in CT, where you need a bronchoscopy, where you have to go in and directly visualize the airway to detect these lesions. And that way, it is basically a combination of CT and bronchoscopy helps the patient, and it's not CT alone or a scopy alone. And especially when it comes to autofluorescence in bronchoscopy, you are able to identify even premalignant lesions and the dysplasia and premalignant lesions, and your planning for further management of the patient becomes easier. And even lesions, the vascularity of the lesions, all these are assessed better with the help of scopy rather than CT alone.
Right. So CT scan is only going to give us a radiological image that there is a possibility of a lesion. What kind of a lesion it is, whether it's actually malignant or not, that cannot be differentiated only on the basis of a CT scan. And especially when the lesions are very small, we cannot differentiate through a bronchoscopy or through the CT scan. We should be doing a bronchoscopy to do that. So this means that there is some kind of a discrepancy in images which can come on a CT scan or a bronchoscopy. So Dr. Abhyankar, so what are the most common areas you think where there could be a discrepancy between a CT scan finding and a bronchoscopy, and where do you think the role of the two modalities are? Dr. Abhyankar, you please unmute yourself.
Yeah, I think these two modalities are complementary to each other and not exclusive. That's the first sentence. The next sentence is, yes, I mean, there would be times when I would rather scope a patient rather than only depend on a CT scan finding. And I think the classic example of that Ganapri has already said is sarcoidosis, where I think those small tiny nodules which I can actually see and biopsy endobronchially would make a lot of sense to majority of the patients for getting a final diagnosis. That cannot be done on a CT alone. So if I have an stage 3 sarcoidosis, which is largely not lymph node based, but it is bronchi and pulmonary beyond it, and a bronchoscopy, which is endobronchial or a transbronchial biopsy, which is going to give me the yield, I would rather do the bronchoscopy in that kind of sense. So I think it's not going to be all or none kind of an answer. It is a relative answer where you have to combine the two most of the times. But once in a while, one scores over the other.
Right. So once in a while, you're absolutely right. Once in a while, the one modality would outscore the other one. And one of the things which I have found very frequently is in a very symptomatic patients seeing something endobronchially. And when you do a bronchoscopy, you find there is just the secretions. So which are there. It's not a mass lesion. So one modality can complement the other one, but it's not 100% that you can rely on one over.
Absolutely. And if I may add, technicians very difficult to really visualize in a perfect way on a CT scan. Much better and almost 100% simply seen on a bronchoscopy and sucked out. So, or even for that matter, a blood clot. Not so very well visualized on a CT scan, but I mean, so much sense, to next to go in and visualize it and take it out either with whatever modalities you have or with a cryo, whatever.
And two important diseases which can mimic each other are tuberculosis and malignancy. So a lot of times you see lesions on a CT scan which might look like malignancy, but they turn out to be tuberculosis when you do a bronchoscopy and bronchoscopic procedure. So that's so they can always be a very confusing thing. And malignancy, we know that it can come in any form. So and tuberculosis can also come in any form and involve any part of the airway. So so there are certain diseases which are known to cause confusion and which require probably both the modalities to make a diagnosis. The other important area is when we are dealing with the bronchoscopy and we have a central airway obstruction. So central airway obstruction can have three components. Either it can be only extrinsic, only intrinsic compression, or it can be both. Dr. Jayaraman, can you tell us that whether a CT scan is the good modality or a complete modality to actually differentiate between these endobronchial lesions, or you think the bronchoscopy scores over the CT scan?
Yeah, in majority of the clinical condition, so we can CT can reliably differentiate type of obstruction. No, most of the time, whether is it intrinsic lesion or extrinsic lesion. So endoluminal or exoluminal. So we can see the CT images most of the time. So in the case of intrinsic lesion, endoluminal lesion will have usually have an acute margin. Acute margin, you can see the image acute margin with the wall. And while extrinsic lesions will have a obtuse margin with the extrinsic compression, CT-wise. So based on the CT, so most of the time we can differentiate whether the patient is having endobronchial lesion or extrinsic lesion, compressions. So we can see most of the time we can differentiate CT-wise. Yes, this is my observation.
Correct. Dr. Abhyanga, please.
The kind of CTs that we get, very frankly, at this point in time, I sit in Pune, which is like reasonably a hub kind of a setup, and I still get bad quality CTs. So I think CT is not always going to decide. So recently I came across a situation where there was a fixed obstruction in the upper part of the airway, where we almost thought there is a mass, and then there was a tracheobronchomalacia beyond it, just 3 or 4 millimeters beyond it. So I think one way or the other, I think I'm not able to decide that this is the only diagnostic procedure. I would say both complement each other, add both to each other and make sense.
Right. I think what Dr. Jayaraman was saying, in most of the cases, CT scan would give you the idea. There would be only few cases where you have some
few cases.
CT scan bronchoscopy may add on that, because to see all the three components, you need to have a CT scan image. Only the endobronchial image is going to give you the intrinsic part of the lesion only. So that is one. So I think the CT scan probably, if you say the number of it will definitely pick up more cases of intrinsic, extrinsic, and mixed obstruction, and thereby you can decide about what kind of a procedure you need to done. Now let's move forward and see the patients who have got no lesions on the CT scan. Still, they are going to be having hemoptysis. Dr. Ganupriya, do you think bronchoscopy is going to help in these kind of patients who have hemoptysis, but you are not actually visualizing any lesion on a CT scan?
So if a patient is presenting with hemoptysis, I think the first and foremost thing that we do is do CT with contrast, and preferably thoracic angio covering both the aortic and pulmonary vasculature. So, and those will be in majority of the cases able to pick up any vascular leaks, malformations, aneurysms, your embolism. Sometimes consolidation can also bleed out, your bronchiectasis, all those cases. But sometimes when the patient is actually bleeding and you're not able to localize anything on the CT, then definitely scopy is mandatory so that you can go inside and visualize and localize the source of bleed. Because many times this most frequently happens in ICU patients as well. There could be airway erosions, mucosal erosions that is bleeding out, ulcers that are bleeding out. So these are not diagnosed in or picked up in CT scans. So there you will have to go in and see and localize a segment, and that helps you to manage the bleed as well, for further planning of the further procedure as well. So scopy is mandatory, especially when the patient is actively bleeding out, even if you don't find anything on the imaging.
Correct. So what you're trying to say is that in case a patient is stable, get a CT scan done, because it's going to give a better understanding of both the central and the peripheral airways that I was talking about earlier. And if there is an emergency, obviously we can do a bronchoscopy. But there are times when we do not see anything on a bronchoscopy, on a CT scan, except for the aspirated blood, and then probably bronchoscopy would help us see some kind of ulcerations in the airway which might be bleeding. So that is one area where bronchoscopy can help in making a diagnosis. And obviously you talked about the therapeutic reason for doing the bronchoscopy over here. Now this brings up to the another very important area, a CT scan versus a virtual bronchoscopy, and how these complement each other, and whether one can replace the other one, or the need for a bronchoscopist, especially when there is a difference between the bronchoscopist in making a diagnosis. So Dr. Sham, can you elaborate on this? When there are endobronchial lesions, can virtual bronchoscopies eliminate the differences that are coming in the bronchoscopist's mind?
So I feel a CT for any endobronchial lesion, I feel a CT scan would kind of help us define the lesion, the extent. It'll tell us what the extent of the lesion is whether it's pedunculated or not. If it's a contrast enhanced CT, you will know the vasculature about the lesion. You will know its extrinsic spread also, if it is spreading outside the bronchus. But I don't think so. It helps us diagnose what it is, unless you have very classical signs of some endobronchial. Uh, it's very tough to diagnose what an endobronchial lesion is. You can probably differentiate it from either a foreign body or something else, which is mimicking or a mucus plug. But so I feel uh, CT scan helps us define the lesion, and it will help us target the area. So if it will help us prepare for biopsying the lesion. So if if it's a vascular lesion, you need to take more preparations and then go in. If you feel if it's a pedunculated lesion, you know that you need to take a snare and go for debulking, rather than if it's a broad-based lesion. So it helps us in those kind of aspects rather than the diagnosis part.
Right. So CT scan can only give us an image, but it doesn't tell about the nature of the lesion. So to know the nature of the lesion, we need to do a bronchoscopy. And same problem is with the virtual bronchoscopy. It can only give us an image and doesn't tell us about the nature, whether it's going to be a benign or a malignant one. And in any case, we are going to be planning to do a further procedure. But maybe by virtual bronchoscopy, it can help us little more understanding where we have to go and take a sample. So virtual bronchoscopy may help if that is available, that software is available with the CT scan center. A virtual bronchoscopy can help us in knowing that. But I think you are absolutely right. Doing a bronchoscopy and making a diagnosis is definitely being required, and CT scan is not enough in that. That brings us to the next question, that whenever we are discussing with the patient that you have a possibility of malignancy. So, Dr. Abhyankar, what all investigations or radiological investigations you would do in a patient you suspect that to be having malignancy, so that you can plan whatever procedure you have to do while doing a bronchoscopy?
This is going to be a 3 hours lecture, but let me try to, if I have a reasonable suspicion of a malignancy, say a smoker, a localizable lesion, bronchoscopically approachable lesion, then I am not going to hesitate too much in just putting in a scope and taking a biopsy. That's simple. As simple as. But if I have a little wider, scope, the lesion is a little peripheral, I am not too sure whether it is malignant or not. then I think I will put everything. I literally put the kitchen sink at him and include everything that I can, including maybe an FDG pet if it is possible, affordable, kind of a thing. So unless until I'm really sure that yes, the procedure which is invasive is going to give me a final diagnosis, I wouldn't put in a invasive instrument inside unless until I'm sure that yes. And last but not the least, a nodule which is completely peripherally sitting just below the pleura. I mean, adjacent to the pleura. And I just can put in a needle. I wouldn't hesitate doing that. Just as I wouldn't hesitate doing a radial bus and a navigational aided bus. So I think all these are extremes, and it's not so very easy to give you a single question. I mean, single sentence answer that this is the right. Thank you.
So rightly said. It's something which requires there are lots of variables to decide about before doing a procedure, especially in the case of malignancy. But if we have a radiological imaging, especially a CT scan, probably we can decide whether we can go for a therapeutic, whether we can go for a diagnostic procedure, whether we can go for a staging procedure, or whether we need to go for a therapeutic procedure. So if we have a CT scan, we can plan these things. And if we have a PET scan, it makes our life little more easier. Right. Dr. Jayaraman, there would be instances where you would say that the CT scan is just showing some abnormality, something irregularity in the airway. And how is bronchoscopy going to help us when the CT scan is not very clear about those lesions?
Yeah. See, the CT images sometimes confusing in the case of whether a patient has extrinsic lesion or endoluminal lesions, or is it a mixed lesions. So even with the visual bronchoscopy and a computer updated imaging modalities, the submucous lesion, submucosal spread or anything, if you think in terms of any submucosal spread of any malignancy, so CT is a very less reliable thing. So bronchoscopy is the ideal thing. We can see the submucosal area, which is the area infiltrated by the malignancy. We have a lot of advancements modalities. Autofluorescence bronchoscopy still is the research modality, but there are autofluorescence that can differentiate. So the coloring mucosal pattern we can differentiate. So in contrast CT, some extent we can differentiate whether a patient has a endoluminal lesion or is it extrinsic lesion, or so this kind of thing we can assess very clearly. But even after contrast, the submucosal thing, the layer identification is very difficult even in a CT with the contrast and all. For that, we have a lot of other bronchoscopic modalities to find out the exact submucosal spread, whether it's a malignancy and all. So this way we can predict CT contrast with the advanced CT scan with the advanced bronchoscopy. Bronchoscopy is superior in these kind of lesions to put a scope and identify correctly. So advanced modalities of bronchoscopy will help in differentiating these kind of some kind of opacities in the bronchus or extrinsic compression we can differentiate.
Right. So with bronchoscopy, we have got certain newer things like autofluorescence or NBA, with which we can differentiate the mucosal lesion from benign to a malignant. So it may just be a theoretical, but practically we can identify these lesions and take biopsy. So I do not know whether how useful it is, but this is something which can be done. The other thing that a lot of our GI surgeons, they send patients who have esophageal malignancies to us to do a bronchoscopy and see whether there is a submucosal involvement or a tracheal involvement of the CA esophagus or not, which may not be very clear on a CT scan. So these are also a submucosal or a mucosal lesions or a airway lesions which can be differentiated with the help of bronchoscopy. And of course, if we have endobronchial ultrasound, that makes life little more easier. So right. So this is more about a CT scan. Now, Dr. Amina, there are instances where you need help from the radiologist and do a multidisciplinary kind of a meeting with him. so that he guides you better for before doing a bronchoscopic procedure. So can you elaborate on what can be the areas where our radiologist can guide us to a better bronchoscopy and a procedure?
Right, sir. So basically, three key pieces of information is what we need from the radiologist. One is, of course, on the site of the lesion. The second would be the information which is necessary for planning our procedure. And third would, of course, be risk assessment when we are going in with the bronchoscopy. So coming to the lesion location, of course, it helps us with the navigation. In case of an endobronchial obstruction and stenosis, a CT scan would precisely show us to a certain extent, to a large extent, show us the degree of length, the degree length and the exact location of the airway narrowing. In cases of foreign bodies, in a fairly decent way, if there is an aspiration of a foreign body, the CT scan can tell us, where it is and which part of the lung it is lodged in. So we can be better prepared for that. Now, as far as the procedural planning is concerned, for accessing peripheral lesions, again, the CT scan allows the bronchoscopist to trace the most direct route to that particular lesion. If we have a lymph node enlargement seen on a CT scan, then we can plan for an EBUS or a basic bronchoscopy with a TBNA even. Now, vascular mapping, as Dr. Ganupriya was also mentioning earlier, if we have a contrast enhancement or an aortogram along with CT chest, it helps us very clearly delineate the blood vessels and identify abnormal vascular structures, which is critical in hemoptysis because in such cases, we normally don't have a lot of time. So we know where it is. We have a targeted approach, just go in there, put in a balloon or a blocker first of all, and then maybe go ahead with a more definitive procedure like a bronchial artery embolization, etc., to control the bleeding if it is a vascular bleed. And finally, risk assessment, again, we have to see the vascular structures primarily, the lesion that we're going to target, how vascular it is. And at times there are other associated pathologies like an abscess or a necrotizing pneumonia or extensive bronchiectasis or fibrocavitatory changes where you are kind of prepared to see distorted anatomy or unhealthy mucosa, etc. So these are the three areas, which one would like to be prepared for before going in with a bronchoscope.
Right. So in short, if I'm not able to understand the CT scan completely, don't shy in going to a radiologist and sitting with him and understanding what possibilities can be there, and this way you can prepare yourself better before doing a procedure. So any doubt, go to our radiologist friend, sit with him, understand what it is. And I have found it very useful, especially as you were talking about doing for the peripheral lung lesions. So understanding the right anatomy, the right segment and subsegment, which Dr. Sham has been showing in the CT scan talk, is very, very important. So because I can target those areas, especially when I am doing a bronchoscopy and not advanced bronchoscopic procedures, taking samples from the representative segment becomes very, very important. I may not be able to see the lesion, but if I'm targeting the segment, I have a very high chances of taking a right biopsy or a right lavage to make a diagnosis. So that's very, very important. And in this, our radiologists are going to be very, very useful when we are sitting with them. But there are certain central airway lesions where we need the help of our radiologist to tell us whether what kind of a procedure this patient requires, whether this patient, which looks to be a very sick patient, a bronchoscopy is feasible or doable or not. So what are these central airway lesions, Dr. Ganapriya, where you would say sit with your radiologist and discuss with him before doing a bronchoscopy?
So in central airway lesions that are causing your airway compression or stenosis, and even other conditions like your post-intubation tracheal stenosis or your post-TB sequelae airway stenosis, these are even tracheobronchomalacia. These are cases where these are complex cases where you really need to sit down with your radiologist and discuss because they can help you in evaluating the airway via imaging to huge extent before you actually go in, so that you are better prepared. If it is an endobronchial lesion they will be able to help you with assessing the vascularity of the tumor, because there are certain highly vascular lesions, high risk cases which are bleeding out, maybe you can go for an embolization prior to you plan for a debulking. And even the amount of compression, whether it is or the type of compression, extrinsic or intrinsic compression, these can be evaluated to a significant amount. And when it comes to these stenotic airways, you might want to plan airway stenting. And in such cases, you can be with the radiologist who can help you with the diameters of the airway, the length of the stenotic segment. So that helps you to plan better for your procedure for management of these patients, including stenting for the measurements. And another thing is virtual bronchoscopy as well, so that you get an idea before you go in. You're well equipped before the actual procedure is. So, and when it comes to tracheobronchomalacia, the standard remains to be the dynamic bronchoscopy in 3-phase. But again, dynamic CT scan helps a lot in avoiding scopy in very high risk patients or in very sick patients, unfit patients. So I think these are the procedures, these are the cases wherein you need to give special attention and be with a radiologist and discuss in detail before you actually go in and see.
Right. So those you rightly said that those areas where if you're going to do a bronchoscopy, but you do not, you anticipate that you may not be able to go beyond the lesion and inspect the airway. Probably taking help from our radiologist is going to help to know the extent of the lesion so that you can plan your procedures accordingly. There could be a lesion which is almost completely obstructing the airway, but it might be very small, and you can do a lot of therapeutic procedures for these patients. So here, the radiologist can help you in guiding and making you understand what the length of the lesion is, and you can proceed further. So right. So now these are the peripheral lesions and central lesions where CT scan and bronchoscopists are going to CT scan and bronchoscopy are going to be complementary. Other area where we are frequently required to do bronchoscopy is in the ICU. So there can be areas where we require. But before that, I need to understand that you have done a CT scan, Dr. Sham, you have done a CT scan, you're planning a procedure. So what are your chances of doing a right procedure or making a diagnosis depending on what you see on a CT scan? Can you predict the outcome of your biopsies or lavage or your TBNA according to what you see on a CT scan?
Yeah, so we have a lot of evidence, right now, especially radial e-bursts. If you have an airway which is leading to the lesion, the yield substantially increases to over 80%. Whereas if you have an airway which is probably adjacent or not leading to the lesion, the yield significantly drops 30 to 40%. But then there it would help me choose the right tool. If there is a central airway lesion, central airway which is leading to the lesion or the peripheral nodule, I can probably use forceps, brushes, lavage, so on and so forth. But if it's adjacent, I would rather use a cryobiopsy where I get a larger chunk of tissue and it tears off the adjacent pathological area as well. So that is one. Second is it can help me assess, like I mentioned before, the vascularity of the lesion. So if you have a contrast enhanced lesion or you see a feeding vessel going into the lesion, that's going to bleed. You can take all the steps necessary. You can counsel the patient accordingly that in the event of a bleed, things can get complicated, prolong the length of stay, so on and so forth. Then the other thing is, like before doing therapeutic procedures, central airway lesions, you can predict an impending collapse. Like if you have a significant mass, and you just have a sliver of a airway which is open, that the moment you paralyze the patient to insert your rigid bronchoscope, the airway is going to collapse and it'll end up in a catastrophe. So in those kind of cases, you give your paralytic only once the rigid bronchoscope is slightly, close to the vocal cord or you entered the airway. So these kind of, small points, but very crucial points, you actually need to sit down with the radiologist or you need to yourself see the CT scan, analyze the CT scan. Then like Dr. Ganapriya had mentioned, sizing of the stents, it's so important. You need to order the stent You can't, oversized stents would give you granulation tissue. It will induce a lot of cough. Undersized stents will lead to migration. So it's so important to see both the inspiratory and expiratory films to, size the stents, etc.
Right, right, right. So understanding a CT scan is very important to not only understand what are chances of picking up the right lesion and making a diagnosis is, as well as to understand what all possible complications can happen when you're doing a procedure. So both the things can be made little more, we can understand them little more if we understand the CT scan correctly. And if our bronchoscope or our instruments through the channel that we are putting in can lead to the lesion, then of course our chances of picking up the right diagnosis is much higher. And over here, the proper understanding of CT scan would help. Thank you very much, Dr. Sham. You rightly said this. Now, coming to the other areas where we are required to do bronchoscopy, as I said earlier, is the ICU. So, Dr. Nitin, Avianka, if you're there, can just an X-ray be sufficient enough to do a procedure in the ICU? Do you think that?
Yes and no in both. One single sentence, because I mean there are times when you don't know whether the collapse is where, and the time is the essence in this kind of a situation. So if it is going to be posterior distal segment of a, say, a left lower lobe, and I am going to go there in 30 seconds and start suctioning, that will save a lot of time and may save somebody a life. Whereas if I have time, then it doesn't really matter whether, as long as I know there is a collapse and I'm putting in a scope and taking a fixation out, um, whether I spend half a minute, 1 minute, 1.5 minutes, I have sufficient amount of hypoxia free time where my respiratory therapist is there to assist me. So I think that can work out, and I think it's not going to be as bad as the whole scenario is. Uh, if I may make one comment on the previous comments which were made, I think one of them was, I think we are talking of basic bronchoscopy, and let's stay to basic bronchoscopy. That's one. So navigational and other things, I think, because I think we will be covering them in other modules one way or the other. So I think, because we couldn't be sort of exhaustive in one single module where we will cover everything from, say, peripheral pulmonary nodule approach to the whole story to basic bronchoscopy. So I think I
You're
would rather
absolutely right.
stay with the basic
You're
bronchoscopy.
absolutely right. But when you're trying to give a complete answer, at times you cross to the other side of the boundary. So that might be the reason. It's very
Even I would, but I am trying
You're
to
absolutely
resist
right. We
not
have to
not to
be
do
we
that.
have to be talking about basic bronchoscopy and not about advanced procedures. That's true. But bronchoscopy, the bronchoscope may be required and to reach to the area to do advanced procedures. So that's something which is complementary and which comes actually together. You can't differentiate truly between them. Now, you rightly said that X-ray may be sufficient in understanding what you'd want to do in a ICU setting, especially when you're trying to take a sample from a consolidation area, or you are trying to take a biopsy from a larger lesion. So X-ray may be sufficient enough to understand depending on the proper
Totally.
understanding of the X-ray, right or left, upper lobe, middle lobe, or lower lobe.
No, no.
Segment-wise, you can differentiate and then take a targeted sample from those areas. Especially, we are required to do lavages in the upper lobe areas. Lower lobe can be easily taken from the endotracheal tube itself. But when the lesions are in the upper lobe and they are not approachable, you think that we were not getting a representative sample, we can go in and take samples from those areas. Collapse is obviously one of the reasons. Dr. Jerem, can there be other modalities which help us in the ICU to target these lesions?
Yeah. In ICU setup, already Dr. Nitin sir told very clearly about that. Chest radiography plays a major role to identify where is the lesion exactly, whether it's the upper zone, mid zone, lower zone, what kind of opacities, whether homogeneous or non-homogeneous. Radiography is a very important role. Apart from the chest radiography, bedside ultrasound plays a major role. It's a real time. We can see any opacities, whether it's the fluid or consolidation, or is it any other mass lesion. So we can differentiate any lesion present in the in the lung parenchyma. We can differentiate whether cystic mass or solid mass. So role of ultrasound in ICU setup, one of the important thing at all. And if you do bronchoscopy, if you want to do anything, so in the advanced tertiary care, coronary care center, they have the fluoroscopy. There's an augmented fluoroscopy. We can use the fluoroscopy. You see the images where exactly we have to we have to target the biopsy or lavage or the wash or brush. We can identify. Apart from the radiography, ultrasound, the fluoroscopy plays a major role in the basic bronchoscopy setting. If we take advanced bronchoscopy, there are a lot of technologies are available, EBS, UVS, and navigation bronchoscope, and a lot of things, ultra-thin bronchoscope. Now, for basic bronchoscope purposes, apart from chest radiography, ultrasound, bedside ultrasound plays a major role to differentiate whether pleural effusion, or it's a consolidation or it's a mass lesion, cystic mass or solid mass. We can differentiate with ultrasound. And fluoroscopy in a case of cath lab or in bronchoscopy suite. So we have basic bronchoscopy we do. We can simultaneously assess the fluoroscopic images, guided biopsy. Also, certain indications we do. So this is the basic bronchoscopy and other investigation. In the ICU setup, we can proceed for the diagnostic as well as the therapeutic purpose. Yes, sir.
Right. So possible X-ray may be sufficient, but wherever possible, we can get a CT scan done of the patient before doing a procedure, or we can use an ultrasound to differentiate between fluid and the parenchymal opacities. Right. Now, this completes one aspect of our bronchoscopy, but we are over here to help the patient and not harm the patients. So there can be areas where we can actually harm the patients if we are not able to prevent an infection happening from one patient to the other when we are doing bronchoscopic procedures. So we have to be very, very sure that we are cleaning the bronchoscopes correctly before going for the next procedure in another patient. So Dr. Amina, what are the essential steps for cleaning the bronchoscope after a routine procedure? Just in brief, can you tell us those steps?
Sure, sir. So first of all, of course, leak testing is something which has to be done. Then cleaning of a flexible bronchoscope may be performed either manually, and mostly nowadays we have these automated endoscope cleaners or reprocessors, which is in fact preferred over cleaning it manually. As far as the cleaning agent is concerned, we normally use peracetic acid with a contact time of 5 minutes. The other options are glutaraldehyde or OPA, again with a contact time of 20 minutes to 5 minutes respectively. Following this, we do an alcohol alcohol purge, where we put in the distal end of the scope into 70% alcohol, and we suction for about 20 seconds, followed by dry suctioning with air for another 5 seconds. It is recommended that after all this, the scope has to be cleansed with a sterile water or RO water. The reusable accessories should be washed the same way. The needles and cytology brushes should preferably be single use. If not, then again should be washed the same way. Then coming to the storage of the bronchoscope after cleaning, it should be hung vertically without any valves attached, which is very important. All the valves should be kept separately. And the drying, the drying cabinets for these bronchoscopes should be well ventilated. And it is recommended to carry out active bronchoscope infection surveillance, preferably at 1 to 3 months interval.
Right. So basically, after we complete our procedure, there are certain areas of the bronchoscope that needs attention. One is the outer body.
Yeah.
That needs to be cleaned, and whatever physically that you are seeing, you can clean it, wipe it with the gauze piece. The other part is the channel. So what I do is, after completing my procedure, I myself would suction at least 25 or 50 ml of saline to clean the channel, and then hand it over to the technician to do that. And the other part is all those accessories that you have used to do a bronchoscopy. They need to be cleaned for the visible visible things attached on them which are not useful, and then it can go for the sterilization procedure, and there are definite steps that needs to be followed. Right. So that's very important. Sterilization of the instruments is very important thing to be done, because you can cause harm to the other patient by transmitting one infection to the other. And some important infections that we are dealing day to day is like tuberculosis. And there was a time when we were dealing with doing bronchoscopies in patients with COVID. So any special care needs to be taken, Dr. Ganapriya, when we are dealing with these kind of infectious cases like tuberculosis or COVID, and what precautions we need to take before while doing a bronchoscopy and after doing the bronchoscopy.
I think as bronchoscopists, we should be taking care as well. We should be properly gowned and with a proper PPE, with proper masks and gown and caps and gloved, properly equipped. And immediately post, so this preferably when you are doing scopy on patients with COVID-19 and tuberculosis and all, it's better to do in a setting that is in an ICU or OT setting, where you have a negative pressure room with at least 12 air exchanges, or a HEPA filter room with at least 12 air exchanges. Try to use low suction pressures, and immediately if you can use disposable scopes, then good. Otherwise, taking proper precautions, you can use your reusable scopes. And immediately post procedure, that cleaning part, like how Amina ma'am said, all that has to be followed. Immediate pre-cleaning, that is immediately after procedure, the cleaning followed by your manual cleaning. You can use your multi-enzyme cleansers that will get rid of the body fluids and secretions inside the scope, followed by high-level disinfection. And all those accessories which we are reusing can go for ETO sterilization, as per how Amina ma'am had described.
So right. So broadly, I would say use all universal precautions,
Yes.
and which are same for doing procedures in any other patient. If you're talking about tuberculosis, COVID was an event where we used to protect ourselves more than we used to think about the patient. But I think universal precautions, right, for our own self as well as for the patient and for the instrument, should be taken in all the procedures, irrespective of what infections or disease we are going to be handling. When it comes to cleaning, there are areas we have big hospitals, corporate hospitals. Then we are seeing people doing bronchoscopy in small nursing homes in small areas. Can we say that there can be a different way of sterilizing the instrument in small nursing homes than in the tertiary care centers, Dr. Shah?
Yeah, so I think in resource limited settings, it mostly would be manual. I mean, they would not have all these the automated machines to wash their scopes. And the best way is the moment you finish the scopy, clean it immediately after you finish. Uh, because and if you can supervise the cleaning yourself if there's a technician there. And what I do is I usually take a protocol of the minimum required steps to clean, and I stick that onto the nursing home where I go to do a bronchoscopy, and I tell them to follow the same steps. So, and it's basically manual cleaning with the water first, and then the brush, separate the valves. Then you can flush it with the detergent, non-foaming detergent, and then you dip it in OPA for the required amount of time. If OPA is not available, you can use peracetic acid or glutaraldehyde. Uh, so whatever is available there, accordingly, we mention the steps, and I stick it onto the cleaning area of then and ensure that every person who comes to clean follows those steps.
Very right, very right. We need to follow the steps. We need to sterilize the instrument with whatever available resources are, whether we have automated system to clean and sterilize, or whether we are doing it manually. We have to follow all the procedure. We have to sterilize the instrument. There is no compromise on that, and we need to be doing that. This is very clear. Now, there is one thing which is called leak test. So I just put it to everybody, how frequently you advise your technicians or you yourself do leak tests. Dr. Nitin Abhyankar, first to start. How frequently you will do a leak test on your instruments?
The leak test is practically done every time after the procedure is over. But more importantly, I think I would highlight that, resource limited or resource rich, or it doesn't matter, because 1998 we saw an outbreak of MOTT in almost every bronchoscopy I did, and that was good 27 years back. Uh, then we realized that we need to do something about this, and what we started doing was a surveillance culture system, which was executed 15 days every 15 days. A sterile scope, so-called cleaned sterile scope, after sterilization, after all the cleaning procedures, was subjected to a culture. And if we grew something, then that was taken as a serious, important abnormality. And last 27 years, we have had only 2 outbreaks when our scopes got old enough to get colonized again. And that means they had to be thrown one way or the other. I mean, they were so old, 12 years old. So I think that possibly is one of the ways. And in fact, I showed it to Dr. Atul Mehta also. Every time somebody comes, we show them our data. And this data is maintained for last 27, 28 years. And every 15 days, we do this. And the only department in the entire hospital which gets good instead of okay is our department. And that's because we keep doing these surveillance cultures.
Good.
Yeah.
Yeah, Dr. Jayaraman, would you agree with him or you do it differently?
Yeah, I fully agree with Nitin sir's statement that leak test is a very, very important thing. Each and every procedures, once you finish the procedures, so you have to see the instrument whether intact or not. So, no, the leak test, once you connect everything and you can keep it in the immersion that no particular water and solution and see any bubbling is coming. So, in the thing, if it is a bubbling is coming, the leak test is positive, which shows there is a breach in the scope, there is a defect in the scope, there is a layer, there is abnormality in the layer, there is a air insufflation, something abnormality. This may infect other people. So infection, colonization, everything is going on. So repeatedly, you do the surveillance bronchoscopy, it shows positive, 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 and cross contamination. This is an important thing. Each and every after the bronchoscopy procedures, you must check the leak test. It will take hardly it's maximum 5 to 10 minutes time. So meticulously assess. So this way we can prevent cross contamination, infection to other patients. So very important. Leak test is one of the important tests we have to meticulously see in each and every bronchoscopy suite. Yes.
Dr. Amina, after doing it? Dr. Amina, what I can tell about my institute and what we practice, ideally it should be done after every procedure. But if we are doing any therapeutic procedure, it is definitely done after every therapeutic procedure, because that injure the instrument. And at the end of the day, it is a must. Logbook is maintained by a technician that at the end of the day, every instrument that has been used will be subjected to a leak test, and then action will be taken. So that's important that we are following in our institute.
Yeah, and if I may add, sir, a bronchoscopist somehow knows when there has been a leak. So, if you're navigating through some difficult airway, or in ICU, if you're doing a bronchoscopy with a snugly fit TT tube, or you've done a lot of procedure, lot of forceps, etc. I think at that time, somehow you get that inkling that, okay, a leak test is now necessary because, I've done a lot of manipulation. So ideally, of course, as per the guidelines after every procedure, but then when you've done a lot of, this thing maneuvering, then too, of course, it becomes essential.
Now, for the benefit of the attendees who are attending this and who are postgraduates, why we are talking about leak tests is two things. Number one, we need to protect our instrument, because if there is a leak test and if we keep doing our procedure, then it can damage our instrument beyond repair. So that's very important, and it can increase the cost of repair. Number two, for the patient, patients can have infections. If there is a leak, sterilization is not efficient. So if sterilization is not efficient, then we can transmit infection from one patient to the other. So it's important for both of us. For the instrument that we are dealing, we need to protect that also, and for the patients also. I think now we have covered almost most of the part of the the topics that were given to us for the webinar, but I would request our panelists and esteemed faculty to please stay and give answers to certain questions which have come up from the audience. I would start with first question with which is by Dr. Raman from Delhi. He is asking when is bronchoscopy preferred over CT guided biopsy in a lung lesions? So, Dr. Sham, would you like to answer this?
So I feel if it's a very peripherally located lesion, a large lesion, uh, and it's not under any bony thing like a scapula or something, you can easily you can easily access it. I feel you should go for a CT guided biopsy. Uh, but in cases of nodules which are somewhat centrally or medially located close to the vessels, when you're suspecting, when you need to stage, you're suspecting malignancy, you need to stage the malignancy also, then you can obviously go for a bronchoscopy. But peripherally located lesions close to the pleura, CT guided biopsy is definitely indicated.
Right. So first thing, you rightly said, first thing is to differentiate whether we are possibly dealing with a mass lesion or an inflammatory lesion or infective lesion. So if you are dealing with a mass lesion, it is present in the outer third and fairly large, close to the pleura. I think CT guided biopsy would be better because our bronchoscopy instruments or bronchoscopy may not yield this. But if it is a central one, of course, that comes to us in our area where we can be more beneficial in doing this, because this will prevent pneumothorax, which is a dreaded complication of a CT guided procedure. But if we are dealing with infections, obviously we have to do a bronchoscopy and take a lavage in that area or a brush from that area. CT guided biopsies are, or CT guided procedures are not to be done unless we are dealing with an abscess kind of a thing where we want to aspirate certain things. So right. So coming to the next question, which is by Sunil from Pune. He wants to ask that when should bronchoscopy be preferred over HRCT in diagnosing the endobronchial lesions? Endobronchial lesions. Dr. Nitin? Dr. Abhyankar, if you're there?
Yeah, I'm there. I think I'll tell you a story
For
where
endobronchial lesions,
somebody.
he's asking for endobronchial lesions.
Yeah, I know. I'll just tell you a story to counter that somebody had attempted removal of an endobronchial carcinoid by a thoracocentesis, and surgical approach 3 times, and had failed, and we succeeded it in the very first attempt that we did it endobronchially. So for obvious endobronchial lesions, please do not subject them to a CT guided kind of a procedure. It doesn't logically make sense.
Okay, so right. So any endobronchial lesion, a bronchoscopy is a better modality to do any kind of a procedure. Uh, uh, if you're just trying to see where the lesion is, then probably a CT scan would help you identify where the lesion is. Nothing more than
That's okay. That's okay.
Nothing more than that.
Localization is the maximum that
can be done. So next question is by Dr. Pratik from Hyderabad. He wants to know, is bronchoscopy indicated in all cases of unexplained hemoptysis? And Dr. Ganapriya?
Any case of hemoptysis that comes to you, I think the first step we do is a CT scan. And if scopy is not mandatory for all the cases, if the CT is normal, like we do get some patients, like usually younger patients sometimes, they must have had a history of viral bronchitis for about 2 weeks, refractory cough for 2 weeks, and they must have had a streaky hemoptysis, maybe 1 episode or 2 episodes, probably a trauma in the upper airway due to the constant cough, and that settles. CT has no findings, and that settles in maybe with your Trenexa a day, a single dose, and then he walks away all right. So I think such cases, scopy becomes unnecessary. But otherwise, actively bleeding patients, yes, I think we need to do a scoping and go in and see from where it is bleeding out, whether further management is required.
Right. So in unexplained hemoptysis, if the CT scan is showing certain lesions, so it becomes obvious that we can take samples from those areas, so that's the area of bleeding. But there can be certain airway bleedings which are not visible on a CT scan, and there a bronchoscopy can help. We have seen aberrant vessels bleeding. We have seen small lesions bleeding which are not visible on bronchoscopy. So I would put it in a very simple way that if you have unexplained hemoptysis, recurrent unexplained hemoptysis, please go ahead and do a bronchoscopy. That can give you more information than what you have received from a CT scan. Dr. Benkar, am I right?
Yes, absolutely agreed. I mean, if you do not have an explanation and the bleeding continues, please do scope.
Yes, right. So, Dr. Behel, Dr. Ajay has written that highly informative and well-structured scientific session for bronchoscopy, basic bronchoscopy. Thank you very much. Now we're coming to the next question by Dr. Rishabh from Jaipur. He wants to know what clinical scenarios would justify immediate bronchoscopy in a hypoxic patient. Dr. Bianca, where would you do a immediate bronchoscopy in a patient who's hypoxic?
If the cause of hypoxia is a foreign body or a mucus plug, I will do it with all the risk. And I'll make sure that my respiratory therapist is there, invasive or non-invasive ventilation is there, depending on the situation. If the patient is already intubated, I'll go through the scope, but then I'll make sure that my respiratory therapist and my other support team is monitoring the patient all the time. But at the same time, I'll go ahead, even in an hypoxemic patient, if I suspect that, okay, there is a plug or a foreign body or something which I can take care of, or for that matter, say airway leads which are clotted and I can just take it with a cryo, I would do it.
Right, absolutely right. So if I'm suspecting what can be the reason for hypoxemia, and that can be handled with the bronchoscopy, I can, or we should definitely go ahead and do in even in a patient with hypoxemia, where if you do a procedure, if it becomes therapeutic, hypoxemia can be managed or cured. Thank you very much for this answer. Next question is from Dr. Jay from Cochin. He wants to know what is the recommended storage protocol for clean bronchoscopes. Dr. Meena, what is the standard storage protocol?
Like I just mentioned, sir, it has to be a dry ventilated space where you have to hang the bronchoscope with all the valves which are disconnected. And yeah, that's pretty much it.
Right. So it needs to be a clean area where you can
Clean
hang
and
your
dry.
bronchoscope straight, because otherwise if you
Yes.
do not hang it straight, it can get curved. So it can hang straight
Right.
without touching to the sideways. So that's the best place to store it, and that's the best place to that's the best way of doing it. Now the next question is by Dr. Abhishek from Lucknow. He wants to know when should bronchoscopy be deferred due to patient's instability. Dr. Jayaraman, can you answer this question?
Yes, sir. So in the case of lung lesions, patient is having requiring bronchoscopy, but the clinical condition in a case of severe hypoxia, or severe instability in the form of any arrhythmia requiring the cardinal support, IV cardinal and other thing and all, and the BP support. Patient requiring 2-3 BP support. The patient is having lung lesion requiring bronchoscopy. First, we have to optimize the patient. So in that case clinical scenario, we have to defer the bronchoscopy time being. So 24 to 48 hours, 72 hours, we have to wait and optimize the patient. Then you do the bronchoscopy. This is the relative contraindication in the case of any instability, unstable patient. Hemoglobin unstable patient is one of the major contraindication. We have to stabilize the patient optimally. Then only we can plan the elective procedures.
Right. Please say, because there are another question by Dr. Anirban from Kolkata. He wants to know when should bronchoscopy be done in a patient with the raised ICP, intracranial pressure, I believe he is asking this, or severe pulmonary artery hypertension. Where will you be doing the bronchoscopy in these scenarios?
Yeah. See, in the case of severe PAH, this is a relative contraindication for bronchoscopy. In the case of increased intracranial pressure due to various reasons, meningitis and whichever thing, this is the relative contraindication. So first to optimize the patient, stabilize the patient, bring down the ICP, and bring down the pulmonary pressure by giving appropriate optimal management. Then he can proceed with the bronchoscopy. In a case of relative contraindication due to PAH, severe PAH as well as the increase in ICP.
Right, right. So as we have
Sir,
discussed
sir,
earlier,
even with a, if I may interrupt, sir, even with a raised ICP, if I am adequately sedating the patient, preventing cough, then it is not a contraindication. So if it is a genuinely indicated procedure, then I would do it with a adequate sedation, maybe at TIVA.
Sure, sure, sure. So the simple answer is absolute indications are very, very few. As I said earlier, would be where the patient is refusing or there is a clear-cut diagnosis being made without doing a bronchoscopy. I think probably they are the only absolute contraindications. Rest everything is relative, depends on how important the procedure is. Whether doing a procedure is going to be helpful and there is no other way of doing it, then please go ahead, do bronchoscopy, taking all the precautions, taking help of your anesthesia colleague. You can go ahead and do these procedures, especially when you're doing it for therapeutic purpose where it can be life saving. So there is another question by Dr. Kamaldeep from Chandigarh. He wants to know in what scenarios is bronchoscopy indicated for airway clearance or mucus plugging. Dr. Abhyankar, in what scenario would you
Yeah.
bronchoscopy in these cases?
So I think, largely these have been well defined in the ICU settings, and a complete collapse of one lung is an absolute indication. A complete collapse of a complete lobe is a relative indication depending on whether the patient is seriously compromised or not, respiratory wise. And I think that's the way it is defined. All others are relative indications depending on whether it's going to really help the patient. That plug is making the patient cough incessantly, and he's losing quality of life and all that, or he remains a little hypoxic or not. All those are in outside the ICU settings, but in the ICU settings, complete lobar collapse, absolute indication. Complete lung collapse, absolute indication. Absolute indication. Complete lobar collapse, relative indication.
Right, right, right. Then there is a question by Dr. Rahul from Mumbai. He says, how do you prevent biofilm formation in a bronchoscope channel? And what are the current WHO and CDSS guidelines? I think we have discussed this thing. If you are taking proper care of cleaning and sterilization of procedure, I don't think there is a biofilm formation going to be happening. So follow those procedures. So this problem will not come up. Dr. Hitesh has complimented us by saying that it's a real good session with good clinical understanding and practical tips that we have given. Thank you very much. Dr. Anil from Surat wants to know what are the clinical outcomes of post-bronchoscopy infection outbreaks. I think clinical outcomes, Dr. Abhyankar, what are the clinical outcomes?
Yeah, I mean, long time ago, we had those outbreaks of Mycobacterium cheloniae, and 1997, 1998, things like that. But I think we have learned a lot from those bad things we did, and our bronchoscopic disinfection protocols of today are so well standardized. I don't think we get bronchoscopy related outbreaks infection unless until you are talking of something like SARS or something like, we just can't control. That's so difficult. And even then, I would say it is not bronchoscope related transmission, but patient to patient transmission, because the patient is waiting outside, two patients waiting outside, one infects the other. And that kind of infectivity cannot be prevented by a bronchoscope alone.
Right. Dr. Naveen from Bangalore wants to know from where should a ball be taken in a patient who has a diffuse lung disease, dependent or non-dependent lobe? Dr. Sham, would you like to answer this?
So I feel so.
Where you should take a
if it's like a DPLD, so I would think it is. I would where new ground glass opacity is there or new consolidation is there, I would rather target those areas. But usually where there's mucus plugging and all that, we usually find it in the lower lobes. If you're suspecting COX, always take some sample from the upper lobes as well. So it depends on the CT findings where you would want to target your lavage and sampling from.
So may I add another aspect to this? If the patient is coming to us with a diffuse lung disease on a CT scan, which area you would or which lobe you would avoid taking a sample from?
Pardon?
Will you be avoiding a particular lobe if you have a diffuse disease? You'll say, let's not do it from this area, do it from the other one. Is the area which you would be avoiding to do a procedure?
So, I mean,
You have a diffuse lung disease.
yeah.
You have options of doing it from upper lobe, middle lobe, or lower lobe. Would you say that I would prefer doing from this and avoid this area?
The anterior segment of the right upper lobe may be avoided, particularly for a transbronchial lung biopsy, because it's likely to bleed more.
So in case you are planning to do a bronch biopsy, then do it from a little dependent areas. But if you're trying to do it lavage, you can take it from all areas. But probably because his question was whether to be taken from dependent or non-dependent lobe, BAL, from dependent or non-dependent lobe. I don't think
it's going to be making much of a difference.
Not going to be taking much of a difference, right? So you can take lavage from any area of the lung. So Dr. Sumit from Patna wants to know how can bronchoscope assist in diagnosing tuberculosis or other infectious diseases. I think the answer is any lesion which is not been diagnosed by sputum examination, you can go ahead, do a bronchoscopy and take a lavage. How often should bronchoscopic equipment be microbiologically tested? Dr. Ashok wants to know from Amritsar. Dr. Amina, would you like to answer this? Microbiological testing. When we sending the sample to the lab?
Yeah, every 1 to 3 months, sir, as per the guidelines. 1 to 3 months ke beech mein you have to do it once.
Yes. So every 30 to 90 days, you can send a sample, take a clean saline, take a sample and send it for microbiological test. So this is what is recommended. Right. Gaurav from Indore wants to know how do you choose bronchial segments for biopsy in ILD? So this is a good question, Dr. Abhyankar. How do you choose which segment to be biopsied in patients with ILD?
If it is a DPLD, that is diffuse parenchymal lung disease, then I will probably prefer an anterior segment of the right lower lobe or the lateral segment of the right lower lobe, because they are the ones which are least likely to cause pneumothorax. But any segment can be taken depending on whether the pathology is maximum, and I think one has to choose an indeterminate area where there is no obvious honeycombing. Say posterior basal segment is mostly honeycombed in an ILD, and I wouldn't rather do a biopsy from there because A, the reason of pneumothorax is higher, and B, I'm going to take only a fibrotic tissue. So I would want to choose an area which is having enough abnormality but less likely to give me complications. That's the way I would look at it.
Correct. So whenever we are targeting to take a biopsy from a suspected diffuse parenchymal lung disease or ILD, Dr. Abhyankar rightly said that we want to have some normal lung also along with this. So do not target too obvious, too diseased area, rather than target an area which is relatively okay and something in the between, right, Dr. Abhyankar?
Yes, absolutely. It should be intermediate. I mean, in between the two.
Right.
So, any role of doing a PET scan in such patients to see which areas are the most active?
Not really. I've tried it, but it has not worked.
Doesn't work.
Very frankly, yes.
So there are certain papers to say that PET scan can guide you the area for taking a transbronchial lung biopsies or a cryobiopsies, but I think it is more theoretical than practical. So for just to take a transbronchial biopsy, you will not subject the patient for PET scan. So that's more.
I think the first order of business is make it safe for the patient. I mean, don't cause a bad pneumothorax and a 7 days admission or a 5 days admission.
Right.
That's the first order of business. Yeah.
How is bronchoscopy performed safely in immunocompromised patients? Dr. Ganupriya, how can we do it safely in patients who are immunocompromised?
Now, compromised patients, one thing, our safety. Second thing is their safety, which includes, especially in hematological malignancy patients, it is highly advisable to use your disposable scopes and leukemia patients and all those. So, and if you are if we're not able to use these disposable scopes, then yeah, you can turn to reusable ones, but provided your infection sterilization techniques are uh, um, good, and that we, because they are prone for infections quite faster than the other patients. So especially in hematological ones, we do resort to disposable scopes.
Right. So disposable bronchoscopes are also useful in patients who have undergone lung transplant. So I will not go into those further things, but any immunocompromised patients, if your scope is very sterilized, if you're making good sterilization protocols, I think it is safe to do a bronchoscopy in all the patients, all the compromised patients. You can use the same bronchoscope for every patient. So next question is from Hemant from Bhopal. What is the protocol if a bronchoscope contamination event is suspected? Dr. Abhyankar, what is the protocol if contamination?
Very frankly, there should not be a protocol when I'm suspecting. I have to prevent it. By all means, I have to prevent it. And preventive methodology is the best methodology. Whatever you're doing, 30 days, 90 days, we do it 15 days, whatever you are doing, do it religiously and make sure that after every procedure, the scope is thoroughly disinfected with the best possible methodology known to you at that point in time and with the available resources. As simple as that.
Right. Rahul from Mumbai has complimented us for a good session. Dr. Rajat from Gurgaon wants to know how do you handle and disinfect accessories like bronchoscope, forceps and brushes. I don't think there is a difference in this. Same way it has to be done. It has to be cleaned with saline for any debris on this, and then sterilized in sterilizing solutions. So what precautions should be taken during bronchoscope in a TB patients? In a TB patients, what precautions should be taken, Dr. Ganapriya? What precautions you should be taking?
Like we already discussed, sir. Basically, these patients, TB, COVID-19 patients, better to do it in a setup where you have negative pressure, in a negative pressure room or a HEPA filter room, like I said, with at least 12 air exchanges. And that we, as a bronchoscopist, we are protected. That has to be ensured. And again, like I said, if possible, use disposable scopes. Otherwise, your reusable is good enough if they are nicely disinfected and sterilized pre and post procedure. So I think these are the major precautions.
Right. So I would add just one thing. Minimum number of people should be there in the room when you're doing a bronchoscopy to prevent infections and risk to the others. And if you're suspecting tuberculosis, then using an N95 mask for yourself becomes almost must. You should be using that to protect yourself and your team also. So it should be done. Right. Next question is by Dr. Rajkumar from Udaipur. He wants to know, why is severe hypoxemia considered a relative contraindication, Dr. Jayaraman? Why is it relative contraindication, severe hypoxemia? What all can happen to these patients?
Severe hypoxia, already I mentioned about the, by definition, SpO2 less than 90% with supplemental oxygen or PaO2 less than 60 millimeter of mercury. If the patient hypoxia due to several etiologies, either ARDS or severe pneumonia or various conditions causing severe hypoxia, if you do the bronchoscope, further worsening of the hypoxia, this may lead to sudden cardiorespiratory arrest and other severe complications. To prevent these kind of things, so we have to wait and observe the patients carefully and optimize the patient. Then only we can proceed with the bronchoscopy. If the patient has complete right lung collapse causing hypoxia, that is the relative contraindication. We can do the bronchoscopy and remove the mucus plug, whatever things and all. If it's a lobar collapse completely causing minimal hypoxia, you can do the bronchoscopy. But severe hypoxia, this is absolute contraindication. No need to do any bronchoscopy. Wait and watch and stabilize the patient. Once patient improves, If the condition warrants, you do the bronchoscopy. Otherwise, there is no need to bronchoscopy. Otherwise, patient may develop severe complications like hypoxemic arrest may happen sometimes in the bronchoscopy suite itself. I want others' opinion also. Shyam and Nitin.
I would add to one thing. This whenever we are doing a bronchoscopy, it is to do some procedure. So whenever we are doing a procedure, it can either cause pneumothorax or it can cause flooding of the segment with oxygen with the saline, and then can further worsen his hypoxemia. So if you are planning to do a procedure, our procedure itself can cause, even in normal patients, hypoxemia after BAL has been reported. So these patients would be subjected to more risk. So that's why it is a relative contraindication. Am I right?
Yes.
Now, the next question is from Piyush. He again wants to know what precautions should be taken during bronchoscopy for TB patients that we have already discussed. Dr. Matthews from Trivandrum, in bronchoscopy, after seeing the lesion, how do we know is this going to bleed before taking the biopsy, Dr. Bhankar? Can we predict
Yeah,
that
I
this
think
is going to bleed?
no 100% way of knowing whether it is going to bleed, because the only patient I have lost in last 35 years, I had no clue that this patient is going to be dying within 3 minutes. But say, for example, a carcinoid, well-rounded tumor which looks like carcinoid is more likely to bleed. So what I would do is keep an APC ready, take a first biopsy, apply APC, keep another biopsy, apply APC, kind of thing. So you take extra precautions when you think there are going to be some things which are more likely to bleed. But there is no 100% way of sure shot way of predicting whether you are going to bleed or not. Another thing which bleeds profusely is aspergillus, invasive aspergillus. If you really, by chance, bite one of those lesions, they can bleed profusely and torrentially. So I think but once again, there's no way of surely knowing whether you are surely looking at this. The last but not the least is mucosa. Once again, can bleed profusely if you biopsy it. But for making a diagnosis, you may be needing a biopsy.
I think yes, we can fairly predict which can bleed, but I think every lesion can bleed. We can predict by seeing the vascularity or the nature of the lesion that this is going to bleed more. If it is very vascular, if it is already just on touching it is bleeding. So obviously this lesion has a high risk of bleeding. But for sure, we cannot say that this lesion is safe, and if you take a biopsy, it is going to be okay, because we do not know what is the vascularity because below the mucosa. So we do not know about that.
And we also don't know the diagnosis. In fact, most of the times the microbiologist or a pathologist is going to tell us the diagnosis finally.
Yes. Same question was asked by Dr. Sunny from Ranchi. Dr. Praveen from Meerut, he wants to ask how should coagulopathy or thrombocytopenia be managed before the bronchoscopy? I think this is beyond the scope of this webinar, how to manage coagulopathy. Dr. Aditya from Delhi has given us a clinical scenario. He has said that there is a 75-year-old male with COPD and hypertension, dilated cardiomyopathy with ejection fraction of just 25%, having speculative lesions in left upper lobe and 13 millimeters subcarinal lymph node. Should we go for FOB or should we go for radial EBUS and EBUS in case? And what guards we should take before doing the procedure, Dr. Abhyankar?
Yeah, I would rather do an EBUS with an EBUS cryobiopsy, because that is more likely to yield a diagnosis rather than doing that, because 25% reaction fraction, it's a little scary kind of a scenario. Whereas EBUS, it's a close scenario, and your needle is going in, and the chance of bleeding is little less, even if you take a cryobiopsy.
Yes. So anybody wants to add anything in this scenario?
So,
Well, Dr. Sham.
So I feel a lot of patients have, though it sounds very sinister, just 25% DCM, but they usually tolerate the procedure well if you,
Yes.
Yeah.
not fluid overload them and you take the cardiology clearance before. the basic steps of not worsening or
It
creating
remains the same.
for a heart failure, because a lot of patients with sarcoidosis, we've done EPASs on with EF of 20-25%. They are not the ones who crash on table. So I feel, but then nevertheless, you have to consider all the possibilities. Uh, Always counsel the patient, well before that. This is the risk he or she is going to take. Get a cardiology clearance prior to going ahead with the procedure, and try to minimize the duration of the procedure as fast as you can. So get the pathologist coming and doing ROSE for you, a rapid onset exam, which so those kind of steps I feel would be more practical.
So right, so there is no absolute contraindication of not doing a procedure in these kind of patients, and Dr. Sham has rightly said that at times these patients are quite stable. They may have 25% ejection fraction, but they do not have any complication during the procedure. So you have to rightly select these. The other thing that probably you can do is do a PET scan and see whether the subcranial lymph node is actually avid or not, because it's 13 millimeter subcranial lymph node and the lesion
May not be. If it is not FDG avid, it is going to be useless.
A left upper lobe, you do not have a paratracheal lymph node, you have a subcranial lymph node. Better do a PET scan and see whether this subcranial lymph node is approachable or doable or not. Right. So we have lots of other questions, but in the paucity of time, I would end our panel discussion over here and question answers over here. And I would like to thank each and every one of you, our panelists, our speakers, for being so wonderfully and patiently answering all the questions. Thank you very much. I hand over to the organizers.
Thank you, sir.
Thanks a lot.
Thank you, sir. Thank you, Ujjwal, sir, for the wonderful moderation.
You did a great moderation, sir.
Shyam and Amina and Gana, wonderful learning with the basic bronchoscopy. Thank you very much, IAB, for this wonderful opportunity.
Thank you.
Are the organizers
there? I think we
Thank you.
we'll
Thank
close
you,
out the
everyone.
session.
Yes, Dinesh, please close the session.